The information in this video is based on my own personal research from available public sources. I am not a medical practitioner, and this is not meant to be medical advice. The video you are about to watch on the topic of colonoscopy as a colorectal cancer screening test is part of a comprehensive, in-depth video that I did on your gut health, polyps and colon cancer, and colon cancer screening choices. I hope you find this segment helpful and informative for you, and I hope you will watch the entire in-depth video. You can find the link to that video below in the description box, above in the cards, and at the end of this video. Colonoscopy is the most invasive of all the screening tests. It's also the most costly, and it carries the most risk and harm to your health. It needs prep time. You have to, a few days before, you have to prepare by having a special diet. And then you have to drink a very strong chemical laxative that forces the body to expel the contents of its entire digestive tract, which can be very hard on the body. You will experience severe diarrhea for quite a few hours, so you must be near a toilet for the entire time. Keep in mind that by clearing your bowels like this, you are flushing out your beneficial bacteria and beneficial microorganisms. And in doing so, you are leaving your colon and your body open to infection from pathogens, bacteria, funguses, and viruses. You will have to have sedation in order to undergo this test because it can be very painful without it, which means you cannot go back to work and you have to have someone to drive you home from this test. So, it's a bit of an ordeal. I mean, it's not a simple, easy thing. And there are complications that I will get into that are possible with this test that you should be aware of if you are considering having a colonoscopy. A colonoscopy is performed by an endoscopist. He uses a colonoscope to visualize the entire colon and rectum. The colonoscope is also called an endoscope, and it's a very long, flexible tube with several channels in it. The front tip has a video camera for taking pictures and video of the inside of your colon during the procedure, so he can view it on a computer. There's also a channel that delivers water and air during the procedure, and another channel for water only. And there's also a channel where the doctor can pass instruments through it, like tiny forceps, wire loops, or snares that are used for the removal of polyps or for taking biopsies. Air or carbon dioxide is used to inflate your colon so that the doctor can see the lining of your colon more clearly. Careful attention must be given to the rate of inflation so as not to overinflate the colon, which would give rise to risk of perforation. Water is delivered as he moves along through the colon to wash away debris and stool so he can see more clearly. This results in a further washing away of your friendly bacteria and mucus lining. And they insert it in through the anus, up through the sigmoid colon, up your distal colon, and all the way around to the end to your cecum. Your colonoscopy is said to be complete if the doctor was able to intubate your cecum, so go right into your cecum, and sometimes they can even see into the appendix, which is, right there too, which is a part of your large intestine or your colon. The actual intestine itself isn't sometimes as easy looking as this. Sometimes you can have a tortuous colon. That means a colon that has a lot of twists and turns inside and makes it a lot more difficult for the doctor to get around and to see, and leaves you more open for problems like perforations or bleeding or injury to this mucosal lining. Also, up here you have your spleen. This is an area of the exam that's very challenging for doctors because they have to get around the spleen. So that's called the splenic fixture right there, where the proximal colon or your transverse colon meets the descending colon, and getting around there can be challenging. And there's often been quite a few problems with perforation there, and even perforation of the spleen. Splenectomies have resulted in that too. Over here is another bend that's considered a challenge, and that is the hepatic fixture. It goes around the liver, And again, whenever they have to make a turn like that, there's always the risk of complications and injury that are associated with that, something to be aware of. It's not that easy. And then the doctor has to be very careful that he removes that tube slowly, because that's how he sees everything. And as I told you earlier, the right side of the colon is much harder for the doctor to see than the left side of the colon. And as such, they've limited those cancer survival rates to the left side of the colon, to detecting lesions on the left side of the colon and not on the right. They have not, and I read one study that said that it perhaps because of the way the cancers arise in the right side of the colon, often flat or excavated or hidden in the mucosa, that perhaps these types of screening methods are just not, the look and see screening method is just not going to be conducive to finding right side cancers early in that fashion, because they are just hard to see. So something to keep in mind if you're considering a colonoscopy, because that is one of the deficits of the test. So obviously the positives of this test are the doctor can see your entire colon in one test, and if all is clear and everything is great, and then you don't have to come back for 10 years. But there's always that possibility that the doctor may miss something. In fact, the possibility is a 25% chance that the doctor may miss something. And they have supported that fact by patients undergoing CT colonography after either incomplete colonoscopies or to verify where lesions may be inside the colon. Often they find other things that were missed in colonoscopy. In fact, CT colonography has found significant additional information in 14% of those who have undergone colonoscopies. Incomplete colonoscopies can be caused by several factors, and they pose a real diagnostic dilemma for many endoscopists. And I've listed some of the reasons here, and those are tortuous colon, which I explained to you was when you have a colon that has many twists or turns, diverticular disease, obstructing masses and strictures, angulation or fixation of the colonic loops, adhesions or scar tissue due to previous surgery, which can narrow the colon and make it difficult for the colonoscope to get through. Then there's spasms. The colon can spasm, causing a problem. Poor colonic preparation with the bowel prep beforehand. You didn't flush out properly. Being a female can predispose you to having an incomplete colonoscopy, as can older age and low body mass index. And finally, operator fatigue. They found that colonoscopies that were performed later in the day resulted in more incomplete colonoscopies due to operator fatigue. Patients can enhance the quality of their colonoscopy by asking prospective colonoscopists the following questions. 1. What is your adenoma detection rate? It's very important, and it should be equal to or greater than 25%. What is your cecal intubation rate? It should be equal to or greater than 95%. And does your report include photos of the end of the colon, including the orifice to the appendix and the ileocecal valve? And finally, do you use split dosing of the bowel preparations? Because effective bowel preparation requires that at least half of the preparation be ingested on the day of the colonoscopy. In general, having a gastroenterologist perform your colonoscopy is more effective than having a non-gastroenterologist for the prevention of cancer and detecting precancerous polyps. However, there does exist substantial operator dependence within gastroenterologists. So just picking a colonoscopist by specialty is not adequate protection against having a suboptimal colonoscopy. Now, colonoscopy does carry a significant amount of risks with the test. And here is a list of them, and they are pretty extensive. And they range from risks from the procedure itself to risks caused by the sedation, as well as the preparation that you have to drink beforehand. And the first risk, which is the most serious and biggest risk of having a colonoscopy, is the risk of perforation of the colon. This can occur when a hole is made in the wall of the colon, either due to overinflation of the colon with air or carbon dioxide during the procedure, or due to forceful insertion and movement of the colonoscope within the bowel, which can cause rupture. And perforation can also be caused by endoscopic interventions like polypectomy. Perforation of the colon is a serious, life-threatening event that has a high mortality rate. Patients quickly become septic due to the toxic contents of the colon spilling out into the rest of the body, causing severe infection. Studies have shown that an estimated 2 out of every 1,000 patients that has a colonoscopy suffers a perforation of the colon. Elderly patients are at particularly high risk for perforation because of the declining thickness of the intestinal wall due to aging. Injury and death from colonoscopy may be higher than reported due to underreporting of incidences. And this can occur because colonoscopies are often performed at different locations than where people end up after they have complications, which is usually at an emergency room or a hospital, and people will generally not connect the dots. Especially sometimes these complications arise days or even weeks after a colonoscopy. Okay, back to our list. Number 2, heavy bleeding. Number 3, the spread of cancer. An incomplete removal of a polyp that has cancerous cells in it can cause the cancer to spread to the surrounding healthy tissue. Number 4 is heart attack, which can occur due to the imbalance of electrolytes that can be caused by taking the bowel preparation and having severe diarrhea for many hours. That can really throw off the entire body. It can cause heart arrhythmias and even stroke. And number 7 is something called post-polypectomy electrocoagulation syndrome. It's caused by a burn inside the colon from the heat that's used to coagulate the tissue after a polypectomy. And it mimics a perforation, and it's very, very painful. And it's an injury to the colonic mucosa and the muscular tissue underneath that causes substantial pain and infection. And number 8 is a gallbladder infection, also known as cholecystitis. Many people unknowingly have gallstones, and they may never be a problem in one's lifetime. But studies showed that the bowel preparation taken before the colonoscopy can cause sudden extended dehydration, which can trigger an acute infection of the gallbladder. Gallbladder infections can also occur as a result of an inflammatory response caused by a polypectomy. Cholecystitis can lead to the removal of your gallbladder. And number 10, a colonoscopy can cause an appendicitis, or loss of your appendix, or loss of your spleen due to a splenic rupture. A colonoscopy can cause a colonic gas explosion. This can be caused by the electrocautery that's used during surgical and colonic procedures. The bacteria inside the colon gives off methane gas and other combustible gases that, when ignited by a heat transferring instrument like an electrocautery, can result in an explosion. The explosion causes a perforation in the colon, and that can cause death. And colonoscopies can lead to additional surgeries, as I mentioned, appendectomies and splenectomies, and that is due to errors made during the colonoscopy, as well as during the polypectomy. Sometimes they don't remove all of the polyp, and then you have to have another surgery, which can actually be very difficult for the second surgeon because scar tissue forms whenever you have a polypectomy. And there are more risks and side effects, like colitis, diverticulitis, bleeding from the rectum, bleeding in your stools, fear, dizziness, abdominal pain, vomiting, nausea, gas pains, oddly shaped or oddly colored stools, kidney damage from laxatives, pneumonia from aspiration caused during sedation, low blood pressure, dehydration, shock, paralytic ileus. That is when the movement of your small intestine slows down and a blockage forms. Internal hernia, pancreatitis, transfusions, and a drastic disruption and loss of your critical beneficial microbiome or gut flora, and of course, death. Individuals at increased risk of complications include the elderly, people with weakened immune systems, patients on blood thinners, people with heart or lung disease, and people with altered anatomy, such as those with diverticulosis, tortuous colon, or obstructions. You should also know that there are no randomized controlled trials to support the efficacy of colonoscopy for the prevention of colon cancer. Now, that's a lot of risks and side effects that I found very disconcerting to read about and to understand when it comes to having a screening test. But there was something else that I read about that I found very alarming, and that is the risk of contracting an antibiotic-resistant bacteria. It's called CRE, Carbapenem-resistant Enterobacteriaceae, a deadly and often untreatable bacterial infection that's being dubbed nightmare bacteria by the Centers for Disease Control and Prevention. Outbreaks of this deadly bacteria are believed to be caused by improperly cleaned colonoscopes and endoscopes. Bodily fluids and other debris can stay in the device's joints and crevices even after cleaning and disinfection. Researchers found residual fluids in 95% of endoscopes they tested. They observed fluid, debris, and discoloration in the channels. Moisture fosters microbial growth and the development of biofilm, which can be difficult or impossible to remove. Researchers confirmed the importance of cleaning, disinfecting, drying, and surveillance of the medical equipment to ensure patient safety. And remember, your colon is already in a vulnerable state of susceptibility to infection due to the flushing out of your microflora with the pre-colonoscopy bowel preparation. So with your immunity already in a compromised situation, it may be very hard for you to fight off these bacterial invaders. In addition to the outbreak of antibiotic-resistant bacteria from colonoscopies, there have also been other infections as well. Those include hepatitis C, salmonella, E. coli, and Klebsiella. Unfortunately, endoscopes can be cleaned and disinfected but not sterilized because sterilization uses heat, which will damage the equipment. It's a very arduous process to clean the endoscopes that go in and out of people's bodies. There's something like 43 different steps that have to be taken to ensure that it is disinfected. The first one being very important to scrub and clean all the channels where things come in and out of, where debris and bacteria can get lodged, and wiping off the entire thing. That's the first line of defense before disinfection even begins. And then there are 43 steps, including a certain type of drying that has to be done in a special cabinet. And if any one of these 43 steps isn't done properly, there could be deadly bacteria that's left on these scopes, and people have died from them. Each year in the United States, at least 2 million people get an antibiotic-resistant infection, and more than 23,000 people die. Antibiotic resistance is being considered one of the biggest public health challenges of our time. Now you might be wondering, as I was, with widespread publicity regarding improper sterilization procedures inherent in the reprocessing of these colonoscopes, why hasn't anyone come up with a better product to protect the patient? And what about protecting the people who handle these hazardous disinfecting chemicals every day? Well, they have, and I want to tell you about them. Invendo Medical has developed the first sterile single-use colonoscope that was FDA approved in September of 2016. Introduction to the product was planned in selected hospitals in the U.S. during fiscal year 2018. And there's another one from GI View Limited called the Aeroscope. It's the only colorectal screening product that is single-use and self-propelled. These two products are completely disposable, which ensures that there is no bacteria or other pathogen coming in contact with the patient. Once it's used, it's thrown away. The Aeroscope was FDA approved in December of 2014 and was supposed to have been introduced to the United States market in early 2016. And I found a third from Microbot Medical, a self-propelled, semi-disposable colonoscope where the parts of the colonoscope that touch directly to the patient's body are disposable. But unfortunately, that means that doctors have to invest in new colonoscopes and endoscopes. They're the same thing, endoscopes and colonoscopes. And that can be costly, so many of them don't. They consistently use the old procedures that they are very comfortable with, and they already have the equipment, so they don't want to just buy new stuff. So I hope you'll ask your doctor about these new single-use, sterile, and disposable colonoscopes. Because if we as patients request these products or choose facilities that offer these new products, then doctors will be more inclined to invest in buying them. It's the simple law of supply and demand in business. Please follow the link now to watch my entire in-depth comprehensive video about your gut health, colon cancer screening, and the choices available to you. And please check out some of my other helpful videos.